Hi everyone, my name is Dr. Kundell and I practice pulmonary critical care and sleep medicine at Mount Sinai. I am the program director of the Sleep Medicine Fellowship here. And today I'll be discussing the evaluation of sleep disorders tailored to the elderly population. So these are my disclosures. So to give you a brief outline of the talk today, we're going to start by describing normal sleep across the lifespan. So I want to start with reviewing polysomnography, sleep staging, and normal sleep architecture, and just discuss some general sleep health tips in the elderly population. Next, we're going to go into some common diagnoses and treatment of those diagnoses that you'll encounter in the elderly population. This will be particularly focused on obstructive sleep apnea and insomnia, and then at the end we'll briefly touch on REM sleep behavior disorder. And then in the end, we're going to summarize some of the take-home points and review the history and approach to a patient with sleep complaints in your population. So I'm going to begin today by talking about normal sleep architecture and how we capture sleep stages using in-lab polysomnography. So normal sleep architecture. So what is sleep architecture? So sleep architecture is really the way stages of sleep are organized during the night. And there can be somewhat of a variation of sleep architecture in normal sleep. But in general, this is how normal sleep architecture is organized. So going through this, there's generally four stages of sleep. N1 is light sleep or transitional sleep, and that generally accounts for about 5% or less of total sleep during the night. Stage 2 sleep is N2 sleep, and that usually accounts for about 50% of sleep. And then you have your deep sleep or delta sleep, which tends to account for about 20%, and REM sleep or dream sleep, which accounts for about 25% of sleep. And in general, more of the delta sleep or deep sleep occurs in the first half of the night, and the REM sleep or dream sleep tends to cycle about every 90 minutes, and more of it generally occurs in the second half of the night. So I want to begin by briefly reviewing the signals we obtained during an in-lab study that'll help us get a good sense of sleep architecture and sleep disorders. So to begin, this is a patient that's come in for an in-lab sleep study, and they're hooked up to several signals. So we obtained sleep staging signals with frontal, central, and occipital EEG leads, in addition to eye EOG leads, which allow for REM staging, as well as chin EMG leads, which also allow for REM staging. We also use limb leads, which allow us to evaluate movement disorders or periodic limb movements during sleep. And additionally, we use several respiratory measures, including the nasal cannula airflow sensor, oximeter, as well as thoracic and abdominal effort belts to really help us distinguish between obstructive or central sleep apnea. And last, we use cardiac leads to evaluate the heart rhythm. So with these signals, we can really get a comprehensive understanding of the patient's sleep, and this allows us to diagnose disorders such as obstructive sleep apnea, movement disorders, and get an understanding of their sleep architecture. So next, I just want to show you some examples of various sleep stages on EEG, which you may not have seen before. So here on the top, you have stage wake with you can see that this patient is awake. They have a very high frequency alpha rhythm here. Below that, you have stage N1 or light sleep, which I mentioned accounts for about 5% of total sleep time. And it's often called transitional sleep because you're kind of transitioning between wake and sleep here. Stage N2 sleep accounts for about 50% of total sleep time in normal sleep, and you can characterize that with these kind of typical K complexes or spindles on EEG. And then you have stage N3 sleep or stage 3 sleep or deep sleep. And this you can see is characterized by really lower frequency delta waves and is responsible for us really feeling refreshed when you wake up. And this is really the most stable sleep and the most refreshing sleep. And then last but not least, we have REM sleep or rapid eye movement sleep, which accounts for about 20% of total sleep time, and it's responsible for memory consolidation. So in this sleep is where we dream, but the muscles are nearly paralyzed. And so this stage of sleep also is where you often see the most cardiac and respiratory instability. And here you can see the eyelids, and you can see the example of the rapid eye movements in REM sleep. So now that we've discussed sleep scoring, I want to move into talking a little bit about the components of sleep health and normal age-related sleep trends. So there are many components that can really contribute to sleep health during all stages of our life, which we'll review today. And these include, but really aren't limited to, sleep duration, sleep architecture, sleep disorders, patient-reported outcomes of satisfaction and quality of sleep, as well as circadian and chronotype of the patient. So this picture shows our evolution through time, and it shows how much sleep is really required as we get older. So as you can see, the number of hours that we sleep per night starts off pretty high when we're toddlers, but after about our late 20s, this number remains constant, and the American Academy of Sleep Medicine generally recommends about 7 to 9 hours of sleep for adults. So we talked a little bit about sleep architecture before, and sleep architecture is really dependent on the stage of development and your age. And so this graph here shows nicely, you have on the x-axis your age, so going from 10 to 85, and on that y-axis you have time in minutes. And so this graph here shows that as we age, there's really a decrease in total sleep time and sleep efficiency. And some other changes that we typically see as we age, you can see that there's a slight increase in stage N1 sleep, which is the light sleep. And in general, there's decreases in stage 3 sleep, which is the deep sleep or slow wave sleep, and decreases in REM sleep as we age. And then additionally, as we age, we have more wake after sleep onset time, as you can see here. And we also tend to have earlier bedtimes and earlier rise times. So I just wanted to show you this graph to let you know that some of these changes that you may encounter in your practice are actually a normal part of aging, such as increased wake after sleep onset, more awakenings, kind of decreased deep sleep or slow wave sleep. And it's really important to educate our patients about this because this is a normal part of aging. So why are sleep problems, so common among older patients? So there's quite a few reasons, but a lot of it has to do with, kind of your schedule as we age. So often after retirement, you tend to have an unpredictable schedule. The regularity in your daytime schedule is no longer present, and then that can affect your nighttime sleep. Additionally, we also know that polypharmacy is very common in patients as they get older. So this study showed that 46% of Medicare beneficiaries take 5 or more prescription drugs daily. And even though seniors represent only 13% of the population, they account for about 34% of the prescriptions dispensed. And so these kind of medications often can either interfere with your sleep and result in insomnia, or they can result in excessive daytime sleepiness. So just some general sleep health tips for patients, and this can be applied to really all patients, but specifically to older patients as they have changes in their daytime routine. So it's really important to get regular daylight exposure and moderate to vigorous exercise during the day. It's also very important to have consistent routines during the daytime, including timing of meals. Setting a consistent bedtime and rise time and allowing for 7 to 8 hours of sleep can really kind of help regulate your sleep schedule, and then really optimizing the environmental conditions where you sleep can help you optimize your sleep. What I really want to highlight here is that when we talk about healthy sleep, daytime behaviors such as getting regular natural light exposure and physical activity can really impact your nighttime sleep. So it's almost just as important what you do during the day to help optimize your sleep at night. So now that we've kind of discussed, kind of normal trends in sleep and some general sleep health tips, I want to talk about the sleep disorders that you commonly encounter in this population. I'm going to start with obstructive sleep apnea. So as you all know, obstructive sleep apnea occurs when you have a partial or complete occlusion of the upper airway that results in a reduction or absence of airflow. So here you see an example of a patient who underwent an in-lab study, and it shows severe obstructive events with these apneas or cessations in airflow in pink. And this is commonly seen in the elderly population. Sleep apnea tends to be more common when you sleep on your back, and particularly when you're in REM sleep. So here is the same full night study of the patient, which you can see, kind of frequent obstructive apneas. These blue lines are obstructive apneas throughout the night. And you can also see associated oxygen desaturations throughout the night. So we all know that sleep apnea is associated with intermittent hypoxemia or oxygen desaturations, recurrent arousals, and rapid swings in intrathoracic pressure. And together that can result in sympathetic activation, endothelial dysfunction, and increased oxidative stress. And so these pathways then link sleep apnea with intermediate risk factors such as hypertension and diabetes, and then can eventually result to progression to cardiovascular diseases such as stroke and myocardial infarction. So this figure really shows the prevalence estimates of sleep apnea in various clinic populations. And you can see that, in primary care, about 37% of primary care patients have sleep disordered breathing. And then this estimate goes up in patients who are obese or in other populations, such as patients who have heart failure or other cardiovascular diseases. Particularly in the elderly, the risk of sleep apnea increases with age up until the age of 70, and then it tends to plateau. And while male gender is a risk factor for sleep apnea, this gender gap in the difference between prevalence estimates actually lessens after menopause. So sleep apnea is actually much more common in postmenopausal females. The whole point of this graph really is to show you the prevalence of sleep disordered breathing, which is stratified by gender and age. So in green, you have patients that are greater than 60 years old. And what I really want to point out here is that sleep apnea, that simply using the diagnostic criteria that we have today, sleep apnea is much more common in patients over 60 years old, as you can see by these green bars on this graph. Again, just briefly touching over the risk factors, common risk factors anatomically are anatomic features such as a large tongue or crowded upper airway, large neck circumference, male gender, obesity. Increasing age is one that I wanted to point out given the topic of this lecture, and also, as I mentioned earlier, postmenopausal women who are not on hormonal replacement therapy tend to have a higher prevalence of sleep apnea. So why do we care about sleep apnea? We know that sleep apnea is associated with cardiovascular disease, including heart attack, stroke, and arrhythmia. So this meta-analysis showed that moderate to severe sleep apnea had a 2.5-fold increased risk of incident cardiovascular events such as coronary heart disease or stroke. And in addition to cardiovascular disease, we also know that sleep apnea is associated with numerous non-cardiovascular outcomes, which are relevant and really shouldn't be overlooked, including daytime sleepiness, loss of productivity, motor vehicle accidents, depression, memory, and concentration. And then importantly, in the elderly population, there is evidence to show that sleep apnea or sleep disordered breathing may potentially advance cognitive decline by repetitive sleep disruptions, and that treatment may potentially delay progression of cognitive impairment. And so it's important to identify sleep apnea as a underlying cause of sleep disturbances in this population. So very briefly, I'm going to go over the treatments for sleep apnea. So with regard to treatment, I think you have all heard of CPAP therapy, continuous positive airway pressure therapy, which is the most common therapy, particularly for patients with moderate to severe OSA. It provides positive airway pressure to the upper airway, and it prevents collapse, eliminating sleep apnea. So here you see an example of a patient who underwent an in-lab attended polysomnography, where you can see that this patient has repetitive obstructive events. So to walk you through this sleep study, on top you have the EEG, which is in a 30-second window, and then on the bottom you have the respiratory signals and the oxygen desaturation, which is in the 2-minute window. And you can see these kind of, this is measuring flow. You can see the cessation and flow, and then associated oxygen desaturation associated with an EEG arousal. In this same patient, this patient has obstructive sleep apnea, and the same patient, you can really appreciate that when they're on CPAP, you have these nice sinusoidal waveforms indicating no evidence of obstruction, and you really have this nice normal restoration of sleep on the EEG without any arousal. So CPAP works well in treating obstructive sleep apnea. So what are some of the short and long-term benefits of continuous positive airway pressure therapy in patients who have sleep apnea? So we know that there is robust evidence that treatment with CPAP and sleep apnea reduces daytime sleepiness, it improves sleep-related quality of life, as well as reduces motor vehicle accidents, and CPAP also actually reduces blood pressure by 2 to 4 millimeters mercury. So we know that there's really robust evidence to show that it improves the patient's symptoms and it improves blood pressure by a little bit. However, these areas in orange, including outcomes such as stroke, AFib, coronary heart disease, or diabetes, it's really not clear. There's several observational studies in non-randomized studies that have demonstrated a significant association between sleep apnea and these cardiovascular diseases and improvements in these endpoints. But randomized control trials really have told us a different story, and I'll go over that a little bit in the next slide. So in the last decade, we've had 4 randomized trials that have really shown no benefit with CPAP in regard to composite cardiovascular risk reduction in patients with non-sleepy OSA, although it did significantly reduce daytime sleepiness and improve health-related quality of life outcomes. So what I really want to emphasize here is that it's important to identify obstructive sleep apnea in your patients who have symptoms, and it's important to treat patients who are symptomatic. But in patients who have mild or moderate sleep apnea and they're not symptomatic, for example, they don't have daytime sleepiness, CPAP is not necessarily indicated. You can do a trial of therapy to see if it helps. But in general, we want to focus the treatment of sleep apnea in patients who have symptoms. So I talked a little bit about CPAP, and so what are some of the other treatments for obstructive sleep apnea that are common? And I'm just very briefly going to touch on this on this slide. So there's dental sleep apnea devices for mandibular advancement, and these are made by dental sleep specialists. So they're worn at night, and they advance your mandible by opening and then they open up your airway and help you breathe at night. So essentially, they advance your mandible and stent open your airway. And these are generally suitable for patients with mild to moderate sleep apnea, although recent evidence has shown that these also work pretty well in patients with severe sleep apnea. And then there's some surgeries that are, can be entertained in patients who have sleep apnea diagnoses. I'm not going to touch on these too much. These surgeries work about 50% of the time. Some of them, for example, there's a uvulopalatopharyngoplasty or UPPP. There's hypoglossal nerve stimulation or Inspire therapy, which you may have heard of. And, that is an option for patients who have failed non-invasive therapies for sleep apnea and dental sleep apnea devices. And then last, I want to point out that, weight loss is also a therapy for sleep apnea. Sleep apnea is very common in patients who are obese, and when patients lose weight, their sleep apnea gets significantly better. And the reason I want to bring this up is because there is a study that is hot off the press that was published in June 2024 in the New England Journal. So this study evaluated the effect of tirzepatide, which is a GLP-1 agonist for the treatment of obstructive sleep apnea in patients with obesity. So the study had two trials. The trial 1, which is on the left side, it recruited patients who were not on CPAP, and trial 2 recruited patients that were using CPAP. And so to kind of distill down the results of the trial, what the trial showed was that there's a 16 to 17% weight loss with tirzepatide in patients with obstructive sleep apnea at 52 weeks. And this 16 to 17% weight loss in these patients resulted in almost a 50% reduction in their sleep apnea severity compared to placebo. And not only did it improve sleep apnea severity, there was also improvements in systolic blood pressure by 7 to 8 millimeters mercury, C-reactive protein, which is an inflammatory biomarker. There were improvements in hypoxic burden. And additionally, there were improvements in patient-reported sleep impairment outcomes. This trial just came out and it was just published in June, and this drug is on track for FDA approval for sleep apnea treatment within the next year. This is weight loss is certainly an important therapy for patients who have obesity-related obstructive sleep apnea. So I talked a little bit about sleep apnea diagnosis and treatment. Now I'm going to switch gears and talk about, well, how do you diagnose these patients, right? What is appropriate for these patients? Is in-lab study appropriate? And when is home sleep testing appropriate? So we know that in-lab PSG or polysomnography is really the gold standard for diagnosis of most sleep disorders, and it allows for evaluation of sleep architecture and sleep staging, and it's generally pretty accurate and has a low failure rate because it is done with an attended technical staff at bedside. However, it is expensive and it is complex, and the access to in-lab sleep studies is limited. And often insurance doesn't cover an in-lab sleep study now until you've ordered a home sleep test. And especially in your population and an elderly population, it may be difficult to coordinate care for an overnight polysomnography for the patient to travel and sleep in a sleep lab. And so home sleep tests are actually much more accessible for patients, and they're fairly simple to use, and they allow the patient to sleep in the comfort of their own homes. They have been really well validated against overnight polysomnographies, and they're approved and commonly used for patients who have suspected sleep apnea. So here are some common examples of home sleep tests, which includes the Apnea Link, the SOMT, the ARIES, and the WatchPat. So this test here on the bottom right is what we often use at Mount Sinai. It's the main test that we use at Mount Sinai. And so particularly this test, it's dispensed to the patient. The study is actually disposable and the data is gathered on a cloud and sent to the interpreting physician. And so as you can see, these tests can be quite convenient for patients as they're done in the comfort of their own home. And so who is appropriate for home sleep testing? So when should you order home sleep testing and when should you not order home sleep testing? So I want to kind of go over this clinical practice guideline for diagnosis of sleep apnea testing using home sleep tests. So let's say you have a patient that comes to clinic and you're suspicious they have sleep apnea. So home sleep testing is appropriate when they have a high pretest probability of moderate to severe sleep apnea. And so let's say they're a patient who you're sure, most likely they have obstructive sleep apnea, then you can consider a home sleep test. However, if you do the home sleep test and the study is normal, they have, abnormal findings of prolonged sustained hypoxemia or central apneas, or if there's technical failure, then we would recommend an in-lab study. So in patients, however, where you have a low pretest probability, where you have a suspicion for comorbid sleep disorders, for example, movement disorders, REM sleep behavior disorder, narcolepsy, patients that have severe cardiopulmonary disease, heart failure, severe COPD, neuromuscular disease, you really want to perform an in-lab study in those patients. And then one thing to keep in mind, especially in the elderly population, often a lot of these not all of them, but a lot of the home tests require, some use of technology or downloading an app on the phone. So if your patient is not very technologically savvy, that would be another reason to order an in-lab study. So, these are the two models of sleep testing pathways. There used to be the traditional model where you had a sleep evaluation, you did an in-lab sleep study, and then you came back for an in-lab sleep titration, CPAP titration for sleep apnea. But now there's the home sleep testing model, which is much more convenient for the patient, where you have a sleep evaluation. You can order a home sleep test in patients who are appropriate for the home sleep test. And then if it shows sleep apnea, you can actually order an auto CPAP machine, which is a smart machine, which has a pressure set between 4 to 20 centimeters of water, and it can determine the pressure that the patient needs at different times in the night. So this home-based testing model for diagnosis of sleep apnea and treatment compared with in-lab sleep study is really non-inferior. And so it's appropriate to use in the right patient, the patient where they don't have other comorbid sleep disorders, and you have a high pretest probability for sleep apnea and they don't have any other cardiopulmonary disease. So in summary, sleep apnea is very common in older patients. It is associated with sleep fragmentation, daytime sleepiness, loss of productivity, potentially depression, cognitive decline. The therapy for sleep apnea should really be guided by symptoms and if they have very severe sleep apnea or significant hypoxemia. CPAP does improve daytime symptoms and it does improve blood pressure, but it really hasn't shown to reduce composite cardiovascular events in large randomized trials. So next I want to discuss insomnia, and I'll try to be brief. I know I talked a lot about sleep apnea, but this is also something very common you're going to see in your patient population. So what is insomnia? So chronic insomnia is defined as a sleep disturbance for greater than 3 days per week for at least 3 months, and it is a clinical diagnosis. So these are some statistics that show that, as I mentioned before, the American Academy of Sleep Medicine recommends 7 or more hours of sleep per night, and studies have shown that insomnia affects up to 48% of older adults, and about a third of the US adults report that they don't get enough sleep, which is at least 7 to 9 hours per night. So So it is a huge problem just in general in the population, but especially in the elderly population. So there are several types and subtypes of insomnia that are important to delineate. So you have psychophysiological insomnia, which has cognitive behavioral features, idiopathic or lifelong or childhood onset insomnia, and paradoxical insomnia, which which has discordant subjective and objective measures of sleep. There's also two main subtypes of sleep apnea by which we categorize patients. There's sleep onset insomnia or trouble falling asleep, and then there's sleep maintenance insomnia or trouble staying asleep. And then, of course, there's secondary causes of insomnia, which are related to mental health, anxiety, depression, medications, or substance use. So really kind of getting a, a thorough history in the patient's medical disorders and medications is very important in these patients. So insomnia in the elderly patients, about 50% of older patients complain of difficulty initiating or maintaining sleep. 30 to 50% report insomnia symptoms. And insomnia disorder is diagnosed in about 12 to 20%. There's a 23% increased risk of developing depression symptoms with insomnia. And overall, insomnia is associated with worse physical health and significant morbidity. So insomnia is pretty common in the elderly population and often is related to changes in lifestyle that occur following retirement or other life changes. So this graph breaks down the insomnia complaints by age, sleep onset in red versus sleep maintenance in yellow. So you can see that you have on the x-axis you have age, and you can see here that in younger patients, sleep onset insomnia is much more common as depicted by the red line. And however, as we get older, sleep maintenance insomnia is much more common, as you can see in the yellow line, in addition to sleep onset insomnia in the blue line. So typically in the elderly population, you see more sleep maintenance insomnia with frequent nighttime awakenings. So this is the classic, you can include this slide, I apologize. So this is the classic Spielman 3P model of insomnia. So you generally have three factors contributing to a lower threshold for insomnia. These include the predisposing factors in pink, followed by the acute precipitating factors in green, and the perpetuating factors in yellow. So both the precipitating and perpetuating factors are usually what put you and keep you over the threshold for insomnia. And then you have the perpetuating factors. So what are some of these predisposing, precipitating, and perpetuating factors? So predisposing factors include biological factors, social factors such as social pressures, low socioeconomic factors, smoking, alcohol use, etc. Precipitating factors can include stressful life events or medical events that may disrupt sleep, such as disability, poor health, financial marital status, depression, anxiety, and retirement. And then you have perpetuating factors, which include poor sleep hygiene, frequent napping, excessive time in bed, etc. So briefly, I do want to touch on insomnia treatment, therapy, but I'm mainly going to focus on cognitive behavioral therapy for insomnia, or CBTI. So cognitive behavioral therapy for insomnia is actually the first line therapy, and it's recommended by the ACP as the first line treatment for chronic insomnia. And this recommendation has really been backed by several societies, including the American Academy of Sleep Medicine. It has the most durable outcomes that persist even after discontinuation of treatment in the long term. So it has outcomes that persist for up to 2 years. So components of CBTI include sleep or sleep restriction, which means eliminating time spent awake in bed, regularizing your sleep schedule, stimulus control, which means eliminating association between bedroom and arousal, cognitive therapy, which really helps you correct some inaccurate beliefs about sleep. There's relaxation therapy, which can include serial muscle relaxation or imagery. And then there's also sleep hygiene, which helps correct lifestyle factors. What I want to emphasize here is that CBTI is a lot more than just sleep hygiene. It's really kind of all encompassing, and it helps you change your beliefs about sleep, and it helps you change your habits around sleep. And so this landmark study was published in JAMA in 1999, and this was a randomized control trial to evaluate the efficacy of cognitive behavioral therapy and pharmacological therapies, both single and combined, for late life insomnia, where the mean age of the population was around 65. And the findings here really show that both behavioral and pharmacologic therapies, so behavioral therapy is in green and pharmacologic therapy is in pink, and the combination therapy is in blue. They are effective in treating short-term insomnia, so up to 3 months. But really only CBTI, which is in green, yielded the most durable improvements in sleep patterns, while pharmacotherapy alone gradually lost its clinical benefit over time compared to at 3 months. So, really CBTI is really the main first line treatment option, and it works the best. So again, to summarize, first line is cognitive behavioral therapy for insomnia. There's compelling evidence in older adults. It improves sleep efficiency, decreases wakefulness, and improves sleep satisfaction. Sedative hypnotics, if they are used, should be chosen carefully. Really, you want to avoid benzodiazepines in this population. Non-benzodiazepines are okay to use, such as zolpidem or Ambien, Zalplon. They do have a better side effect profile than benzodiazepines, although they can still increase fall risk. You can use other medications such as melatonin or trazodone, depending on what other comorbidities the patients have. And you really do want to avoid things like antihistamines, which are often found in the main ingredient in over-the-counter medications because they have a lot of anticholinergic effects. And so next I'm just going to talk about, very briefly, REM sleep behavior disorder. So what is REM sleep behavior disorder? REM sleep behavior disorder is the failure of the expected atonia in REM sleep, where as I mentioned earlier, in REM sleep, your brain is active, but your muscles are near paralyzed. But REM sleep behavior disorder, you start acting out your dreams because you have the lack of atonia in REM. And so the patient can often present with violent motor behaviors such as kicking, punching during sleep. It tends to be more common in males over 60 years old. And the reason that this is important to identify in patients, because this may be the earliest sign of Parkinson's disease or Lewy body dementia. And then importantly, untreated sleep apnea can often mimic these symptoms of RBD. So often if you have patients that present with some of these symptoms, you can treat their sleep apnea and they may get better or go away. But you really should refer them to a neurologist if they're reporting these behaviors, because if they are at risk for developing Parkinson's disease or Lewy body dementia, you want to catch it early. And additionally, SSRIs and other medications can sometimes induce these symptoms. So what do you do when a patient has suspicion for REM sleep behavior disorder? You should order an in-lab study to evaluate for REM sleep without atonia. You should also evaluate for untreated sleep apnea. You should review their medications. SSRIs can sometimes precipitate these symptoms. And really review safety precautions. You want to make sure your patient is safe when they're sleeping. You don't want them to kind of fall out of bed. So you really want to review, either having a mattress on the ground to prevent falls or bed rails. And as I said earlier, they may benefit from a referral to neurology and sleep medicine, and definitely they will benefit from a referral to neurology and sleep medicine. So just to quickly show you an example of REM atonia. So on the top, you see an example of normal REM sleep. You can see these nice rapid eye movements on the top here. Um, and there's atonia on the chin EEG, chin EMG. Below here, you can see this patient has loss of REM atonia. So you can see loss of atonia in the chin lead and then the limb leads with these spikes and movements. And this is pathologic and would be characteristic of someone with REM behavior disorder. So in summary, I'm going to give you a quick approach to this sleep patient. Make sure you get a detailed sleep history. You really want to get a holistic understanding of their sleep, their bedtime, their sleep latency, their nighttime awakenings. Any snoring, witnessed apneas that could suggest sleep apnea, daytime sleepiness, dream enactment, which would suggest REM behavior disorder or restless legs. It's really important in these patients to get a social history of shift work, caffeine or alcohol use that can precipitate insomnia. Ask about drowsy driving, and then really thoroughly review their medication list, which can often result in insomnia or excessive sleepiness. And evaluate to see if they're appropriate for home sleep testing if there's a high suspicion for sleep apnea, or in-lab testing if there's concern for other sleep disorders or they have complex cardiopulmonary disease. So what are some of the take-home points here? Sleep problems are very common in the elderly population. Insomnia and sleep apnea commonly co-occur in older patients. For patients, for OSA patients, treatment should really be driven by daytime symptoms. Treatment options include, but are not limited to CPAP, dental sleep apnea devices, and weight loss in obesity-related sleep apnea. For insomnia, pharmacotherapy alone is not recommended as the first-line approach. CBTI can successfully reduce insomnia symptoms, and sometimes it can even help improve adherence to CPAP therapy in patients who have comorbid sleep apnea or comorbid sleep apnea with insomnia. So I hope this was helpful. Thank you so much for your time.